So, and as we are about to start the panel debate, I would like to introduce Magnus Hald, who is a newcomer on the scene here. Magnus Hald is a psychiatrist. He is in charge of a clinic in northern Norway, and we have learned, Magnus Hald, that you have already established a medicine-free treatment alternative at your clinic. So first I will give the words to you to say a few things.
Thank you. Is this working? Yes. Yes. As you said, I'm responsible for a psychiatric facility in northern Norway as the director of psychiatry or mental health and drug abuse at the University Hospital of Northern Norway. We are responsible for psychiatric center services for Troms County and Ofoten, that's the area around Narvik, and also responsible for hospital services for Finnmark in addition to our primary catchment area. And we also have some responsibility for Nordland County, regional responsibility. And within this region we have between 200 and 300 psychiatric beds for adults. And now we're developing 6 so-called drug-free beds. It seems that this is something that some people think is very dangerous and very challenging. I think it is in very many ways. But I'm not sure if this really poses a danger to psychiatry, which I would really have hoped that it could. So to me, it's a very big challenge to develop this drug-free unit, not outside of psychiatry, but as a part of psychiatry, and a unit that relates to the rest of our service system. So I hope it will be possible for this unit to develop treatment programs that reaches far beyond this unit, because 6 patients, that's a very small unit. And it's very limited possibilities what you can do within this unit. So it's very important for me to develop this as a natural part of the psychiatry or the mental health service system that we have. And it's not going to be something that we develop on the side of it. So I would just emphasize that. And as I said, the main goal for this unit is to develop drug-free treatment programs or courses of treatment for individuals. And the basic idea here is that it should be possible for patients to choose not to use neuroleptics. That's the basic idea. And this should be possible whether or not doctors and other professionals means that that's the best idea. So in many respects it's very simple, and we should of course be able to achieve this within the system that we have. And why haven't we? This is really something that we should think about. Why haven't we been able to do that? Although now when we're developing this, people come from all over and say, we already have this. But this is something that Fellesaksjonen really hasn't understood, and that this is always in place. And my experience is that this is not in place. And the development of this unit, which was established in our hospital 1st of January this year, I think this is the first unit of its kind within the psychiatric hospital or mental health hospital system that I found in the world. Like Soteria House, these other things that have been tried out, they've all been established outside of hospitals as some kind of alternative. We're trying to establish this as a part of the ordinary system. So it has to connect very closely to the rest of the system. And it's very challenging for me to try to figure out what is it to take the user perspective seriously, both when we try to develop an organization and when we try to give good treatment to people. What is this? Some people seem to think that when you talk about evidence-based practice, that there is some kind of primacy giving to research, the research knowledge, which is an important part of evidence-based practice. But evidence-based practice is also experience and also the user's choice. And some people seem to think that the users should be able to choose between different things that the evidence-based evidence has brought forth. I'm not sure if that is user perspective. Mental health seems to be very occupied with trying to redefine people's problems in medical terms, although we don't have a medical diagnostic system. We just have a classification system, but we use the classification system as if it was a medical diagnosis system. This is very strange in many ways, and also creates some kind of strange foundations for evidence-based knowledge. And we should be very aware of that our diagnostic system is a classification system. So when we treat people for schizophrenia with drugs, we don't really know what schizophrenia is. We just know how we classify different symptoms. And the drugs, they work on the body in different ways. And we should be very aware about how drugs work on the body. And I think it's and I think that the establishment of this drug-free unit in our place has really emphasized the debate about this. At least in where I work, I feel that, for instance, when you talk about what is defensible or justifiable, because we should only give defensible treatment to people, like you talked about. It should be we should give defensible or justifiable treatment. 𝗀𝗺𝗵𝗊𝗆. And what is that? So we discuss when is it defensible not to give drugs. Well, then we also get into discussion when is it defensible to give drugs. And then people giving drugs, they say that, well, we always inform people very well. So I guess that Røssberg, he informed the patient that was taking Leponex that this might cause your bone marrow to stop producing blood cells, and you might die if you don't take your blood tests and are sure that you don't get an infection, and that this medication might reduce the white matter of your brain, and this medication might get you into risk of getting heart disease. So I think it's very good that we inform patients very well about all these problems with drugs. And I guess and also since I'm the leader of this hospital, I can see how drugs are being used, and I see that, for instance, we have much of what's called evidence for drug use is evidence for using a single drug in a rather low dose. But I see very many patients get several drugs in higher doses, and I haven't seen the very good evidence for that, not even within the framework that kind of recognizes a kind of evidence. So I think but these are debates and discussions that are really being enlightened by the development of a drug-free unit. But still, we're very much at the starting point of making this unit, and we really don't know what it will be like. And we will try to there's a person that will try to do some research about what we're doing, but it's very difficult because we really don't know. Like you said, we really don't know which patients will be there, because we don't know who will apply to be there, and we don't know who it will be possible to accept, and we don't know who it will be possible to make a good cooperation around for being there. And we really don't know who will be there, and as you also said, we don't really know what is the intervention, because there will be different interventions. Most people think it's very important to have specific interventions. I'm not quite sure, but we're working on that, and we're trying to find out what will be good interventions for these people. And that also emphasizes the question about what kind of interventions can be justifiable within specialized healthcare, within a specialized healthcare system. Can we do like anything? Acupuncture, you mentioned. I mean, is that a good idea, or is it not a good idea? And when is it a good idea? And for what is it a good idea? Some people think it's a good idea that it's more easy that you can use it to help people sleep. Well, then you might use it in a place like this if it can help people sleep, because sleeping is a good idea. But I don't know. Is it justifiable or is it not? Thank you.
Thank you, Magnus Hald. For the audience, I would like to say that you will have the opportunity later to ask questions to the speakers. But first, we will have a few minutes or quite a few minutes actually, where first I invite all the other speakers to say something for 2 or 3 minutes, commenting perhaps on what the other speakers have said. Then we have a discussion here, and then later on you will have the opportunity to ask questions. So we will now proceed with, I think we stick to the sequence that we had. With, so I invite Håkon, Rian, Ueland for the first comment.
Thank you. When you play soccer, it's said that you should aim for the ball, not for the person, because that's good practice. Dr. Røssberg, you didn't aim for the ball. You aimed for the person all the time. You cherry-picked statements made by people in Fellesaksjonen. You characterized Whitaker as Trump. And I don't think this is a good way to talk to people. You didn't come across as a good psychiatrist. I was also told that the WHO, we are a group, we don't want psychiatry. We don't want psychiatrists. I'm the leader of WHO. I think we do want psychiatrists, but we want good psychiatrists. That is very important, and that's a big distinction. And what you did, it didn't show you as a good psychiatrist, I'm sorry. It showed you as a person who is not concerned with truth. There are so many falsehoods in what you said, it embarrassed me. And I feel I'm quite upset with your presentation. Yes. I would like to thank I would like to give you credit. It's quite courageous to sit here with this group and to present your views. That takes a lot of balls. So that's pretty good. Thank you.
So you're next.
Thank you. I think I should have more time. No, we are turning down my microphone. I think I should have more time than the others, therefore against one here. So, but I had many comments to the previous lectures, but I think I start by commenting the last one. It was not me who characterized him as Donald Trump. It was James Coyne, a psychologist. So just that's said. But you said that the 𝗵𝗴𝗊𝗶𝗴𝗺𝗏 needs psychiatrists, and Magnus Hald, I think, said they need psychiatrists and psychologists. But if the patients, which we don't know who is, shall receive every treatment they want, as I heard Magnus Hald now, and what's the main aim of the Fellesaksjonen, why do we need psychiatrists then? Why do we need research? Why do we need psychologists? If they are going to just say, I want that. We have several similar problems in the somatic. I don't know if you remember 𝗊𝗵𝗃𝗃, that was a big problem at the 70s and start of 80s. The patients wanted it. Should we treat cancer patients with mistletoe? I don't think so. But the patients wanted it. I think Radiumhospitalet should buy the mistletoe to the patient. I think we agree that there are no quite good evidence for treatment, psychiatric wards without medications. I haven't seen any in this lecture. And what's fascinates me still, and that's the presentation to Robert Whitaker. What does the study says? They said that mostly, I could go deep into each of them. They said that patients with a lot of psychiatric symptoms receives medications. Yes, they do. And those who don't need them doesn't get them. That's mainly what he is saying. I wonder if Whitaker has received any critics or something at the 𝗊𝗿𝗿𝗍𝗏 study, I don't remember the other study. I see the Harrow study and 𝗀𝗏𝗿𝗍𝗏 study. Has there been any critics against that? I still wondering also about the 𝗀𝗏𝗃 project. I met 𝗀𝗏𝗵𝗃𝗀𝗃 in Stavanger in 2000, and I cooperated with him in my PhD. He was a nice person. And is there something you don't mention when you are citing the 𝗀𝗏𝗃𝗃 project? I remember we were presenting at the same workshop, and he get his paper in 𝗔𝗿𝗵𝗃𝗃𝗃, which you showed. You showed that. But what you didn't show was the editorial from Will Carpenter, who said, if you are going to publish that paper, I am going to write an editorial who analyzed this study in quite another way. Go home and read that. That's quite different from what Whitaker said. He mentioned a Cochrane review from 2011. That was from 𝗀𝗵𝗵𝗺𝗃𝗃𝗃. He was a student with 𝗀𝗏𝗵𝗃𝗃. And 𝗀𝗏𝗵𝗃𝗃 was at Kingsley Hall at Leing's clinic, where he get his antipsychiatric teaching. So I could tell you about these studies. I can go in detail, but I also wonder, how does these studies fit in with the studies I mentioned, that people who use antipsychotics has less mortality? If you start early with treatment, they get less symptoms over the years. This is still questions.
Okay, thank you. So, Robert Whitaker is next.
Okay, I need an hour. No. Listen, you know, one of the things that's so interesting is that every study that psychiatry doesn't like, they'll attack. There's always something wrong, okay? And they'll get someone to say, oh, there's this problem with the methodology or something like this. You saw who these researchers were, and you saw what they concluded, not me. These were top researchers. So if you have some people then are picking at me or picking at the researchers, you have to read psychiatry is a guild that protects its interests. And what's its product? What became the product increasingly of psychiatry? It was prescribing drugs. So if you have studies that end up saying that the unmedicated people, or the people who stop taking medication, are doing worse over and over again, what are you going to do? And you don't have a single study you can point to where the medicated patients did better long term. Not one. Doesn't exist. So what are you going to do? You're going to kill the messenger. You're going to attack the people doing the research, that sort of thing. That becomes revealing on its own. I'll tell you one quick story, and then I'm going to go to his point about the studies he was mentioning. When Martin Harrow did his study, and he first published it, or he first got ready to announce his 2007 results, he went to his peers at the psychiatry department at the university he was at, and you know what they told him? Don't publish this. It's bad for psychiatry. And he had trouble getting it published where there was peer review by other psychiatrists. And one of the things that you see in his initial publication, he says this, and this was reported in Anatomy of an Epidemic. He says, it's not that the drugs made things worse. It's just a matter of that people with good prognosis were the ones who got off. And all we really found, therefore, was that there's a select group of people who can do okay without the medications. So I interviewed him about that. And you'll see in the book that's reported. And I said, but wait a minute. That's not what your data shows. I said, listen, you have the good prognosis patients who got off did better than the good prognosis patients who stayed on. The bad prognosis patients who got off did better than the bad prognosis who stayed on. And then I said, how about your data when we look at the milder disorders milder disorders on did worse than schizophrenia off? And you know what Martin Harrow said? A light bulb went off, and he went back to his data, and he said, oh my God, there's a problem here. And now he even cites me as saying that he sees his data in a new light, and now he's questioning whether antipsychotics in fact make things worse. Okay, so my point is, why is it that every time there's a study that goes against psychiatry's interests, they just try to kill it? Rather than be open-minded and learn from it and try to get better care. Isn't that the goal? Now, in terms of the 𝗙𝗏𝗏𝗃 study about mortality that he refers to, that supposedly these drugs that cause diabetes and heart conditions and all lengthen lives. Believe it or not, I don't know if I'm supposed to say this, I was asked to be a reviewer of that study by Lancet. It's an 11-year outcome study. Initially, they had it in a way that if someone had been on medications for 20 years and was dying from, say, heart problems or obesity, and then got off 2 weeks before they died, that was attributed to being off medication. That's how they were grouping the deaths. So I said, Lancet, you got to reject this, because the question is about, how about length of use and mortality rates for length of use? So go look at the study. Now, there is a group that supposedly never used drugs during 11 years, quite a number of patient years. It's from a Finnish registry, if we're talking about the same study. And that group that supposedly never used drugs, which is an older group, by the way, from the get-go, that becomes your baseline for saying, okay, here's the mortality rate over 11-year period for all patients, okay? And they say, look at the people on drugs, who basically are younger, by the way, had a lower mortality rate than that baseline. But you know, go look at that study. You know who had the lowest rate over the 11 years? The group that used drugs 6 months or less. But they didn't point that out. So in fact, what you see, if you look at the drugs with increasing use, you see increasing mortality rates. So the group in that had the lowest mortality rate over 11 years was the group that was on for 6 months or less. And Finnish people said, as far as people not taking drugs, there's all sorts of problems with that registry, et cetera, et cetera. They did it. But that study doesn't even show what it's said to show. How about the increased risk of suicide? We saw something about if you're off meds, it's 10 times the risk. Did you hear that today? It's often cited. You know where that study comes from? It comes from people released from a hospital who stopped taking the drugs for the first month. And you know, you're right. You come out of a hospital, you've been on meds, and you stop taking those drugs, you're at really high risk of suicide. That's true. But that's not a no-med state. That's people who've been hospitalized and put into despair, and often they don't like the drugs. And in fact, if you've been on the drugs and come off abruptly, you're in trouble. And a Danish study found that your risk of suicide after leaving a hospital is 44 times higher than it would be otherwise. That's not a fair comparison. My point is, so much of what we hear that derives societal care is this sort of data organized to support a practice that benefits the guild. And one of the things that you're doing here tonight, okay? Oh, and by the way, the TIP study, I think you're talking about the TIP study, which is the early duration study. It's not a study that compares no medication to medication. What the study does is it looks at people who got into care really early, I think it's like after 5 weeks, got medicated, and then we follow those people. And then the other group got into care like after 16 weeks of untreated psychosis, and they get medicated at 16 weeks too. There's no unmedicated group that's being compared there. What you're comparing is the somehow early treatment with antipsychotics compared to treatment that is initiated a little later with antipsychotics. Does that confer some long-term benefit? There's some questions about whether it really does at 10 years. But my point is, if you want to have a real study here, compare early treatment with drug or with a type of care like at Open Dialogue, which doesn't initially use it. That's a fair comparison. But you can't say that antipsychotics are effective when you don't even have an unmedicated group. Does that make sense? And really, finally, what, from my perspective, the Open Dialogue is a proof of principle of a type of care where you don't immediately use neuroleptics with anybody, and you start to sort out who can get off without being on the medication, and then who can use them just short period of time, and then who needs them long term. A selective use model that begins without initial use, but a lot of care. And you see these great outcomes that are now repeated at 5 years and 10 years. And I don't know if you noticed it with the comparison between the Swedish and the Finnish data. I forget exactly, but I think it was like 17% were regularly maintained on drugs with the open dialogue. And then in Sweden, it was like 87 or something like that. And the outcomes were so much better with this group. That's just that's like a proof of principle about doing things differently.
I'm sorry, but
Sorry, went too long.
Yep.
Thank you.
Yep. So, Seikkula, please.
Yeah, of course, there is a lot of things to comment, but one, what I have been more and more concerned is the very poor validity of psychiatric research. And I first became known when we at the 90s we were in this research, and that was a period of time in which it was said that every psychotic patient should be medicated, because it's a psychosis in a neurotoxic process that you have to stop it, and it increases relapses if you do not medicate. And we started very early for get very other type of outcomes, and then I became interested that what is the background, what is the evidence for this treatment, and then I started to look at the research, and I was very surprised because I really didn't find any research about it. And then I realized that how these medication trials are done in psychiatry, they are done in a way that, as Bob said, that first everyone is on medication and then it's stopped. And then you follow 6 to 8 weeks about the decline of symptoms. And if there is a difference in the group means in advantage for those who have used medication, you made a conclusion that the medication is needed to prevent the psychosis. And this is very non-valid research. It tells nothing about the long-term outcome of the medication, and there are some studies showing that the difference that is between the groups in 6 to 8 weeks is no longer there when you follow the groups in 1 year, but in 1 year it really could be the difference. But all the treatment of excellence guidelines for schizophrenia, for instance, in Finland, they refer tens and hundreds of this kind of studies with group comparison. And the second point, what is group comparison? You may have a kind of group comparison difference statistically, even if 70% of the population is under the same variation. So that those people who are having the drugs and those people who are not having the drugs, 70% of those could be on the same variation, and only 30% could be outside of the variation. And you make the conclusion for use of medication based on this 30% variation that may be after 6 or 8 weeks better compared to those who did not use of the medication. It's very, well, this is very shortly said, but the main idea of these randomized studies, empiricistic studies, are based on this kind of evidence. And then we come into the catastrophe that has happened nowadays, that when you follow, you isolate the phenomenon, and then all of a sudden you exclude all the other information, and now you are, as happened in the studies of Andreasen group, to realize that it is the medication that start to make change in the brain function and in the brain tissue. And it's very much background is that the validity of this research that is behind the recommendations in psychiatry is very poor. And it's a very frightening thing, because it's more or less use of power based on this kind of conclusions that are made based on a poor validity that are repeated and then put into practice. And that really worries me, and that's why I also have started lately to speak more and more that the research mainly should be done in the real practice, because in the real practice you also have information about the complexity of the phenomenon and of the ideas of treatment. That's my comment. So.
Thank you. So thank you all. In all fairness, I think, Røssberg, that you have a point. You are a bit alone in the panel, so I will give the word to you now.
This is not working all the time, so I hope that you can hear me. I have actually a lot to say. I don't know where to start, but
You have 5 minutes, actually.
I have 5. Oh, let me start by saying that if we could find a psychosocial intervention without medication, that it was effective, I would embrace it with all my heart. I have researched psychosocial intervention for 20 years. But when this come up, that we should not use medication, I was, wow, that could be very, very difficult. To have psychotherapy with patients with 3 voices in their head, lots of negative symptoms, it's very difficult to get an alliance, a relationship, to work with the problems, etc., etc. It's very difficult. Ask Toni Morrison. He is the only one who has done a study about that. I have to state once more, we don't know anything about drug-free wards. We don't even know about side effects. You said that we should say something about Leponex and clozapine and the side effects of that. Of course, they are terrible. But what are the side effects of drug-free wards? Can somebody say something about that? We know that there are pretty much more side effects in psychotherapy that we used to believe, but we never measure it. That's a big draw. As I said in the lecture, it would be much more and a higher correlation if we took the number of psychotherapy sessions instead of medication and compared that with disability pension. So that's another option. But I have to admit, I think both the Morrison study is very interesting and the Wondering study is quite interesting, but we have to be critical about it. You have to analyze everything. We do that every day at the university. We look at the data once more. We don't say, oh, no, we don't trust this because it got the other way around. In fact, I think all my colleagues, if they have found something very interesting, they will follow it for everything it was worth and work day and night. So that's okay to the open dialogue and need adapted treatment. It started in 1960 and still there are no good studies. I sat and looked at the comparison between Stockholm and Norway Lapland. What was the difference? What was the similarities? How did you diagnose them? That's questions which are very interesting. I hope you believe in diagnosis at least. They have many faults, I know that, but that's for sure. But Wondering study, I think, also is fascinating. They show that by reducing and low doses up to 7 years, they get better functional outcome. And that's quite interesting. Maybe you have used too much antipsychotic in the follow-up. But one interesting finding is also there. 80% of those who should discontinue or stop, in that group, 80% used medication. That's much more in the TIPS project, where 65% at 10 years used medication. And that's quite interesting. They used actually more of the patient used medication than in the TIPS study. So it's not like that everyone should have medication. And we have known since 𝗀𝗃𝗃 and that some of the patients could do fine without medication. That we know. But since we don't know who they are yet, we have to say advice to take for all of them. We don't know who will have an effect of it. And it's another thing, I think, I think I can come back.
Okay. Okay, so a few more comments from the panel before we open to the audience. Who wants to go first?
You're quite concerned with studies and solid evidence. Could you tell me where in the brain does the psychosis sit? Where is schizophrenia? And what are the exact mechanisms of antipsychotics that treat this thing somewhere? And what objective test can you use? What blood work can you set up? What CAT scan, MRIs can you use to see, oh, there's schizophrenia or psychosis?
This has been quite interesting. We started out with drug-free wards. Now we have been discussing paternalism. We have discussed diagnosis. We have discussed how paternalistic the psychiatrists are, and now even what schizophrenia are. I think we have, as I said in my lecture, we have 123,000 studies of schizophrenia.
But will you comment on this question?
Yes, I'm going to do that.
Okay.
And we start. We don't know exactly, but we are starting. I don't know if you saw the studies from the Bergens milieu, where they start to entangle the mystery of hearing voices. It was quite interesting, and it's a lot of studies doing interesting things, and we are starting to get the big puzzle together. It's not that doesn't exist. We start, and we have a long way more to go.
Okay, Seikkula?
For 60 years you've been treating with antipsychotics, and you still don't know what you're treating. That's very interesting to me.
This is, I didn't quite follow when you said that, are there used diagnoses in the open dialogue studies? Of course there are used diagnoses.
What's the reliability on that?
It's tested and it's reported in the papers if you read it. Yeah.
Good?
Yeah. So it's very interesting to be in this kind of debate that there is no evidence of open dialogue treatment, and I don't know any other approach that has been as much researched and studied as open dialogue, not even in psychosis. And you try to avoid seeing things that are there available, and perhaps it's very much a question that if you are taught as a researcher only look of this very narrow point of view of the research, you try to exclude everything else, even if that other things would be much more valid for the idea of treatment. Science journals did not have any difficulties of referring to open dialogue studies, but it seems that some professors in Oslo do not acknowledge that. So that is,
Okay, thank you. Now I would like to turn to our very patient audience and invite you to come forward with a few questions or comments. And as we have only about half an hour left, there's no time for extensive speeches, so you have to restrict yourself to short comments or questions. And 𝗀𝗵𝗏 will hand over the microphone. Let's see where the first hand comes up.
As you said, Røssberg, you claim there is no evidence for medication-free wards, but now, when a place in Tromsø is open, in Sita at the 𝗀𝗵𝗶𝗀𝗵𝗆 Recovery Center tries that, several other places are open in the official there you can get an excellent basis of research when the wards are going on. There you get your research material, and then you can compare with ordinary units. Thank you.
Hello. I started my practice in working in the psychiatry at 𝗀𝗵𝗆𝗆𝗃𝗏𝗏, and I'm very sad that the 𝗀𝗵𝗆𝗃𝗏𝗃 now has left. Oh, this way. Because because I don't think the result from 𝗀𝗏𝗏𝗺𝗏𝗃, where they could do whatever they like. I was in a when we had meetings there, we had to face the door because it was dangerous to turn back to the door because the patient with or without the clothes were coming running in and out. And I think what they found out from 𝗀𝗏𝗏𝗃 was that it was no use continuing that line. And I ended being in the TIPS project and saw what we did there, especially with the family therapy who was psychoeducative, and how happy the parents were and how happy everybody was. And when I think back, when we had Haley, you probably have heard of Haley, who said he cured people from psychosis with his way of therapy. Of course, we weren't Haley, but we tried it, and I can stay awake all night thinking of what we made those people suffer, whatever I should say. So I'm so for Røssberg, and I think it's so brave of you to be here and say what you say. And of course, Whitaker has some fantastic results from all his studies, but he didn't say anything much about what these studies really were. It was just a lot of numbers. Sorry.
Do you have a question?
No, not really.
That was a great comment.
So you're not alone. Anyone else?
Rønnaug Stensrud, I'm an occupational therapist. I wonder, how do you define psychosocial intervention?
Comment on that?
Should I answer?
Both of you can.
Yeah. Well, for me, I don't have any other definition only by referring both words, psycho and social. So it's a kind of intervention for help of our client that is based on psychological meetings and, of course, focusing on the social elements of the lives. That's what I really think that open dialogue you could call, for instance, as a kind of psychosocial intervention in that respect.
Røssberg, you want to make a comment?
I agree. There's psychosocial interventions without medication who try to help the patients with the difficult thoughts, feelings, functioning, not at least. And that's what? Milieu therapy, early intervention, some sort of things.
Vi så det.
Thank you. Thank you. Yeah, my name is 𝗀𝗏𝗏𝗺𝗏𝗺, and I'm working here in Oslo as a researcher, but I'm original from the Netherlands. And in the Netherlands, we have a slightly different history. That involuntary medication is by history thought of as more severe than seclusion. So we had a lot of debate on how to deal with aggression in mental hospitals. But I understand now that here in Norway it is slightly different, and I get the impression that almost all patients who are admitted in the hospital with severe mental illness are getting medication. So what do you do with patients who are psychotic and don't want to take medication? Are they automatically receiving involuntary medication, coerced medication, or do you send them home?
Okay. Great question from the Netherlands. Yep.
How to answer that? If I understood it right, you said, how do we treat patients with psychotic symptoms who don't want medication. We try the very best we can to, with the best of therapy, include the family, good milieu therapy, occupational functioning, etc., etc., etc. But what was that to laugh about? Of course we do. And I can just refer to the TIPS project. At start, over 80% took medication with no out of free will. So, and what was interesting, if you looked at the data, those who were on different laws, admitted unfrivillig, 𝗀𝗵𝗶𝗆, they were worse when they were admitted than those who were not. But at 2 years, there were no difference. They had the same quality of life, they had the same symptoms, etc., etc.
Magnus Hald, yes?
I would say that most of the patients that are coerced when they go into psychiatry, they will be treated with coercion if they don't take the medication voluntarily. But those that are voluntarily in the hospital, they will be they will be sent home unless they behave in a way where they thought, where the doctor thinks that they should be coerced. Then they will be coerced and forcefully treated. And then there's also the question about when do you, the difference between coercion and taking things voluntarily. And that's been an important thing for the 𝗀𝗏𝗃𝗁𝗍𝗔𝗍𝗏 and for the drug-free treatment place, is that we should not only, people should not only be able not to choose drugs, but they should also not be talked into it. So because that seems to be an important part of psychiatric practice, to talk people into taking medication, because medication is often experienced as so difficult to take. I would also like to have a comment with something you said earlier, that there are many patients that psychiatry don't think that need medication, but the problem is that we don't know who they are. And since we don't know who they are, we could choose not to give anyone medication or to give all medication, and then psychiatry chooses to give everyone medication. And that's different. And I also think that's very different from what you said, that those that don't need them don't get them. You said that earlier. Those that don't need them don't get them, referring to neuroleptics, because we give neuroleptics also to people that we see that they do not get better with their psychotic symptoms, but they still keep getting neuroleptics. So when I look into the patients in our clinic, I can see that people that are chronically psychotic, they still get neuroleptics. So how come they get neuroleptics if they don't get better? And there's also a question in this: they don't get it if they don't need it. Who decides who needs it? And that's an important question. And I think that's a difficult question, because sometimes sometimes it's very difficult to say who should be able to express a view on this. I mean, when should the doctor be able? When should the patient be able? Generally, the patient should be able to decide this for him or herself. But that's and I hope that developing a drug-free program will make that more possible, because I think that we experience now in the psychiatric service system that if someone comes in with a lot of psychotic symptoms, that we have to try drugs in a way, and we have to help the person try drugs. I think we have to debate them about who should be able to decide. I mean, who should make this decision? That's I think it's a difficult question. And I would just add a last thing, and that is, I don't mean that like anything goes, but I mean that these are problematic issues, and I think it's very good that a drug-free program kind of highlights these issues and makes all these discussions, because I think that's important by itself.
Okay. So there are two panel members who will make just short comments, and then we'll go back to the audience. Short comments.
I think it's interesting when you come to a psychiatric ward and you're very upset and very scared, and you consider perhaps you're psychotic, and you ask perhaps you should try some antipsychotic drugs, and then if you say, I want to hear about it, and you're not really competent when you come to psychiatric ward, because it's so difficult to get into them. But still, you are capable of saying yes, even when you're given a list of all the side effects, and they are long and they are severe. But if you say, no, I don't want it, and you consider it incompetent, then yeah, you can take it anyway. There's something so degrading in the system of drugs that it's rather scary, because you sit there and become God over people's lives. You say, you should take this medicine. This is best for you. I don't care what you think. I know what's right. I think that I wish for psychiatrists to consider their power a bit more.
So, Seikkula?
Yeah, of course I understand, because we are here for discussing the drug-free services, so that this is a main issue to discuss about. But in my mind, it's also very important to have in mind that to look at the medication issue as a part of the entity of the treatment, and what concerns, for instance, open dialogue. It never has been a kind of non-medication idea. That's not at all the main point. And for me, the main point is not to think that you have to stop medication and then doing something else, but it's the opposite. You need to have a, let's say, a kind of psychosocial, very active psychosocial way of helping with people, in which medication can be a part. And what our results show, that if you have that, then you have access to decline the role of medication. There is a risk that this medication issue becomes a kind of too big, that we only discuss about it, if it is medicated or not medicated, and that's the problem. And that's, of course, how the research are done, either medicated or non-medicated, and that's, again, very non-valid idea of the treatment on the whole.
Okay. Røssberg, you want to comment? Yeah.
A lot of questions. I want to say another thing. I wonder if the 21 million Norwegian kroner you are using on the 6 drug-free wards in northern Norway, could we use those differently? Could we have ACT team, which we know works? Could we have early intervention? Could we start it with family work? You could do a lot. Inpatient settings is the most expensive treatment we get.
They are doing all that in Tromsø, I know.
Oh, they are? Yeah. Mm-hmm. So you are so exclusive that you have all the money already. Then I rest my case if you have all this. Of course, a lot of treatment with medication could be better. I think the psychiatrist should reduce quicker. They should be more aware of when they should give antipsychotics, if they are effective, evaluate that continuously. And there's a lot of things. Maybe we could use those 21 million other places in Norway to improve the treatment.
Okay. Ranveig, do you know who's next? Okay.
Hei, Bjørn Lydersen fra Norsk Sykepleierforbund, Norwegian Nurses Organization. I think it's for a long time it's been health services on the terms and conditions of us professionals. It's time for a change, that the health services should be on the terms and conditions of the patients. And I think psychiatry has been an area where we've been the first to doubt that patients know their own best. And I think it should be a stop for that now. I think we should have a dialogue with the patients to ask them what is the best for you. It's not automatically that when you have a mental health problem, then you are capable of knowing what's best for you in any terms. And I think it's too bad as well that that's the kind of admittance in a hospital where you have an effective gatekeeper saying that we can offer you that kind of treatment, that kind of treatment, and that kind of treatment in addition to medication. First medication, and then you can have the rest. It's right that we don't have very much research on the effect of medication-free units, but we know also that the effect, the quality of the research on the use of medication is very doubtful. The same medication would probably not be accepted as for use if the efficacy was the same on different somatic illnesses. What? When I hear here then that it's the way of debating is to laugh at people. I don't think that's the right thing to do. I just wanted to say that the Norwegian Nurses Organization, we have a political platform on mental health, amongst other political platforms. And one of them is, we know that many people say they have good effects of medication, and that's fine. That's very good. But our point is that we want people to have a choice, a real choice. So we want that people should have a possibility, a real possibility, to choose a medication-free alternative if they want to. So, and my question would then be to Røssberg, the laugher, when we speak of the health services on the patient's terms and conditions, pasientens helsevesen, what is your definition of that? Would that be to what kind of accept would you give to a patient's wish to what kind of treatment he wanted to? I could say to the Dutch lady here, my impression would be, if you come to a ward, we do whatever we can to persuade you to take medication if you say you don't want to. Would you do that, or do I mistake you? Thank you.
I need to answer that. I did not laugh. I said, what? If you think that the antipsychotic medication now is so bad that it wouldn't be approved, if I heard what you say correctly today, that's quite a misunderstanding. I think they would at once get approved for showing improvement in symptoms. What I mean about the patient services, I think I said that quite clearly in my lecture. I think the patient should choose whatever they want, what they think is best for them. But I also think we should not have an evaluated treatment in the official health services. That's my opinion.
Okay. Before I give the word to Einar Plyhn, stand up Einar, I think we should give Einar a big applause because he has made this conference and got all these people to come here.
Thank you. There are many more than me that has made this conference possible, but thank you. I have a question for Røssberg. Do you consider your talk here today as evidence-based? And I ask this question because listening to your talk, I got quite confused about what you mean by evidence.
That was quite a thought.
Just before you reply, I think we have 4 more people on the list, so we will let them come forward first, and then you and the other in the panel may have a final comment.
I am Per Oren from Aurora. we want to try to stop the way the psychiatrists make decisions about medicine practice by starting a court trial against the state and look at how the journals of the patients are filled out by the doctors. We think we hear that there are so many lacking things in the journals that our lawyer will try to address this problem, and hopefully, if we get enough journals from you, you may approach us with your case, and if your journal has very lacking, that is, it is not made according to a modern concept of health practice that we should have in our country. If you think your journals and your decisions about medicine have been wrong, come to us and with your case, and we will look at it. If it is good enough, we can use it against the state.
Okay, I think you made your point. Thank you.
Okay.
Yes, I will not tell my name because of confidentiality. You are so obsessed with not bringing in the family. I'm the father of a daughter who finished her education, hit the wall. On the second consultation with a psychiatrist, she got neuroleptics. And 2 psychiatrists have now said this was terribly wrong. But she has lost her life from 28 to 41 with a full degree from NTNU, ready for giving her life to her profession. And I'm shocked about your attitude to your profession.
Okay,
the human
you.
brain.
I think you need to finish
The
now.
human brain is the most complex thing we have. And if you had noticed what Nancy Andreasen, who is the biggest researcher of all probably, she said to New York Times that this medication is harmful. It reduces the gray area of the brain, and it should, if it should be stopped, it should be reduced to a minimum.
Okay.
And that was 10 years ago.
Yeah. Okay, thank you. It's okay. We stop it. So we have 2 more from the audience. We don't have time for more, sorry. Yeah.
Okay, thank you. I was reflecting on wishing a little bit curiosity about getting systematic feedback from the patients. I think that there are some trenches here, and I'm a little bit saddened to that polarized debate. So I think that systematically asking the patient, even if they have some persisting psychotic ideas, on how may we help you? Has this treatment been useful? And to make a more coherent evaluation of functional results, and to monitor this more systematically throughout the mental health services.
Thank you. So, last comment or question from the audience.
I'm Peter, student in dentistry. I have a question for Røssberg. You seem, like Ueland said, quite concerned with studies and evidence. Throughout Whitaker's lecture on the basis for antipsychotics for schizophrenia, it's a very lacking scientific evidence. Do you acknowledge that, or do you still deny it?
Okay, thank you. So now we have a few minutes left, so the panel members now have a chance for a last remark. Who wants to go first? Whitaker?
Listen, you know, these debates do get contentious. But listen, what happens, I think, first of all, you're to be congratulated here in Norway. You're taking this on. It raises all sorts of questions. You're the first country that has taken this on in this way, so congratulations. And it's not easy, but congratulations. And just from the outside is this, you know, society gets driven by narratives. And so we've had this particular narrative for a long time in psychiatry, which put drugs at the center of it, in the sense that they were necessarily helpful. And that's the narrative that's been out there, and that it was an evidence-based practice. And now what you really have is a counter-narrative that is out there that is challenging that conventional narrative. And when narratives clash, it's not easy. But things do change, paradigms shift, and one of the things is maybe evidence, when closely examined, can help foster that paradigm shift. And the biggest thing here is this, in society, and I travel all over, societies are unhappy with the type of care they have now. It's not lessening the burden of mental illness in society after society. So what you're doing here is part of what I think is a larger effort to rethink how we consider mental problems, how we deal with them as a society. We've had one paradigm, it really hasn't worked. We need a new paradigm, and God bless you all, because you're here tonight in part of the struggle to see what should the future be like. And that's a really brave thing to do.
Thank you. Ueland?
Yes. 𝗀𝗵𝗿𝗃𝗀𝗺𝗃𝗃𝗃 Recovery Center was mentioned. There are 500 people waiting in line to get in there. They can't. I think that's quite a strong point, that there is a need for medication-free alternatives. And if you go to a psychiatric ward and you meet some of the people that sit in a closed ward especially, who sit in a chair, drooling, shaking, you look into their eyes and you see just about nothing. Then you also understand that medication is not the solution, at least not the way that it's used. It might help if you're totally running around and you're very scared and you feel very afraid. Of course, perhaps you need to cool down, you need to get some sleep. But if you continue years after years, you give 10, 20 different medications at the same time to the same person, and then at the same time you hear psychiatrists talking about quality of life. That really upsets me, because that is not quality of life, sitting in a chair drooling and shaking and not being able to speak, to feel, or anything. That is not quality of life. And yeah, I would like to see the psychiatrists who would dare to take the same drugs that some people are given in our Norwegian wards. Please, try.
Thank you.
Well, of course, there's plenty of things in my mind, but perhaps the things that comes more and more up in my mind is I move in many countries. I've been in Norway since coming to Norway since 25 years ago, quite regularly. And what really has struck me and impressed me is the strong idea in your society to have. This was perhaps the first country in the world in which I really realized that the voice of the people who have their own lived experience within psychiatry is very strongly present in the society. And I suppose that this is also the background of this new idea of having this drug-free idea, and that's a very impressive. I'm very impressed, and that's why I also like this debate. Of course, of course, I start to think that it's not only a science, it's very much of ethical values of human life that we discuss all the time. So that I'm a part a scientist, but I'm part very moved of this discussion.
Yes, I would agree very much with you. The ethical questions around this are very central. And I would also say that we are trying to develop some research that can follow the development of the unit that we have, but we still don't know if we'll get money for that. We hope we will, and there's a big interest in trying to develop some research. And on a national level, there will also be some research by 𝗀𝗺𝗶𝗱𝗀𝗺𝗺𝗺. What's that? Ask user project, which will try to look into how the people that uses this kind of unit, how they feel about it. And I do hope that we will be able to develop this drug-free unit in such a way that the individual patient will feel that he or she can, get on in life in a more meaningful way. I think that's our basic goal. And I also hope that we will be able to develop it in such a way that the field will see that there is some possibilities here. Maybe there's something there, and look into what that can be. So that's the basic goal.
I think we all have the same goal to make the best treatment for patients with psychosis. I doubt that, but we disagree on how to do it, I think. What I think was missing here is you have misunderstood me if you don't think I mean family work and psychotherapy is important. I worked 20 years to try to increase the use of family work. So that's extremely important. No, that's I've written about 15 papers about it. So that's a little. No, and I think the systematic feedback is very important. We have to be much better to, does this treatment work? Or if it doesn't, we have to change. We have to do something else. That's very important, and I think that's one of the biggest issues we have to be better at. But what I want to tell is when I raised this debate in June, I was so eager and I was so occupied with psychosocial intervention. I have been researching that for so many years, and that's where my heart is. And then I start reading about medication. I was in many ways forced to read about medication. And I think we have a lot just in research and methodology and evaluate the negative effects, etc., about how they have used it in the medication research. Because what I have read is not what is coming up here. This is quite different. I have read evaluation from the best professors and scientists in the world of what they think, where they evaluate everything, pros and cons. Is it positive? Is it not positive? Is the side effects worse than the effect? A lot of those papers, and I think I am in many ways changing my thoughts about that, because there are so much good studies, and I think we have to recognize that. Yes, and to yeah, I think I said thank you for that.
Thank you. So a great thank you to our speakers and for the panel discussion, and thank you to the audience. Good night.